Good afternoon, everyone. Thank the organizer for giving me this opportunity. So I present this two-incision technique for gynecomastia, dynamic fat flap technique. This is basically done for Simon's grade 2 and grade 3. Pre-operatively, we make the patient in a standing position and we mark the midline and mark the lower border of the breast, upper border of the breast, lateral border of the breast, and these are the markings in the standing position. Once the markings have been done, the patient has been placed in a supine position with the arms abducted, and these are the instruments we commonly use for the gynecomastia surgery. Initially, we place an incision at a 6 o'clock position, a stab knife, and use artery forceps to tunnel the area. After that, we use a 3 mm liposuction cannula to tunnel all the areas of the breast, superiorly, medially, laterally, and inferiorly to the same incision, and we infiltrate the tumescent using the same incision. Usually we use a ringer latex along with the adrenaline and Harris. Once the infiltration has been adequately done, then we start doing a liposuction through the same incision. We usually start from the right side in the superior quadrant. Once the adequate liposuction has been done on the right side, then we go to the left side. This is the left side we are doing the infiltration. We are doing a liposuction. In the meanwhile, when we are doing a liposuction, continuously we are seeing the amount of the thickness of the skin by pinching the area. Once the liposuction has been done, so we go for the gland excision. So usually in our technique what we do is the gland is dissected anteriorly, posteriorly, inferiorly, laterally and medially, and we keep the attachment in the superior part. That is where our pedicle is situated and the flap gets the blood supply from. The incision is usually the 3 o'clock to 9 o'clock position, and once the incision has been placed, so we dissect the dissection. The surgery is very standardized. The dissection is usually below the nipple. The below the nipple we keep about 5 to 8 millimeter of the thickness of the tissue, and the rest of the area we dissect. This is the incision being placed. We use sharp scissors and create a plane where our right angled small retractors are used. A plane has been created, and the right angled retractor will just go in, and the rest of the flap in the superior part, the dissection has to be done. The dissection is usually with the use of both cautery as well as the sharp scissors. Once the superior dissection has been done, we go medially and then go inferiorly and then go laterally. We cut all the fibers. This is a medial dissection. We go up to the prepectoral fascia. We lift the gland from the prepectoral fascia. This is a dissection inferiorly up to the inframammary crease, and this is a dissection laterally. Once the complete gland has been dissected from all the sides, we deliver it outside. and we put a finger inside and see whether the dissection has been complete up to the marked lines. So once the dissection has been complete, we augment the markings what we have done pre-operatively. This is a dissected gland delivered outside from the lateral view. So normally our chest is, we have a normal tissue in between the skin and the muscle. That has to be retained. That's the basic principle of this technique. So what we do is, we cut out the extra gland and retain the normal thickness that has to be normally present in between the skin and the muscle. Usually the thickness is usually the inframammary crease, intraclavicular skin thickness and the upper abdomen thickness. The same amount of the flap has to be retained. The extra amount of glands has to be cut out. This is a fat flap that has been dissected, and we give a wash. Once the wash has been done, there is a final trimming that has to be done, and then we start suturing the fat flap to the skin, to the soft tissue. We usually use around 5 to 6 sutures at the corners of the flap. Once the suturing is done, then we go for the suturing the subcutaneous tissue. We usually use Vicryl 30 undyed for subcutaneous tissue, and then 50 undyed Vicryl for epidermis. Here we close this thing. The same steps have been repeated on the other side. This is a gland has been delivered. The extra gland has been trimmed off. The gland sutured and the skin sutured. Once we finish the surgery, then we make the patient in a semi-prone position, assess for any deformities, any contour deformities, and then we do the plaster dressing. After surgery, usually we give the antibiotics and analgesics for 5 days, pressure garments after second day. We ask the patient to take it easy, walk around, read books, watch TV. We usually advise open shirts for 10 days, and we usually call them for the dressing after second 48 hours, and usually the response is like, wow, they are amazed with their own chest. These are few of the results of gynecomastia with the same technique, grade 3 and grade 2 and grade 3. Thank you very much.